You're listening to Who Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about patent ductus arteriosus. We'll go over the physiology and presentation, imaging features, and when to intervene. Patent ductus arteriosus, or PDA, is a communication between the descending thoracic aorta and pulmonary artery, which is necessary for fetal circulation, but which should close within the first 24 to 48 hours of birth. Prematurity and maternal rubella predispose to PDA. In PDA, all the excess volume is going to the lungs, so you get left heart enlargement, not right heart enlargement. PDA with Eisenmenger syndrome will have pulmonary hypertension with a loud P2, radiographic prominence of the central pulmonary arteries and absence of peripheral arteries known as pruning, and right ventricular hypertrophy on ECG. Initially, PDA will produce a continuous machinery-type murmur at the second left intercostal space. However, with the onset of shunt reversal, this murmur may no longer be evident. The diastolic phase of the PDA murmur will be increased by isometric hand grip due to the increased systemic vascular resistance. Patients with Eisenmenger physiology due to a patent ductus arteriosus may present with pink fingers on both hands, but blue and clubbed toes due to reversal of the shunt toward the lower extremities. The finding of differential cyanosis and clubbing of the toes but not of the fingers, is pathognomonic for chronic right-to-left shunting through a PDA from the pulmonary artery down to the aorta, and a right-to-left shunt at the ductus distal to the subclavian arteries. Therefore, the 2018 Congenital Heart Guidelines say measurement of oxygen saturation should be performed in feet and both hands in adults with a PDA to assess the presence of right-to-left shunting. That's a Class 1 recommendation. How do you tell PDA apart from pulmonary valve regurgitation on TTE? Pulmonary valve regurgitation will have a diastolic-only CW Doppler signal, whereas PDA will have a continuous CW Doppler signal. In addition, the color Doppler jet of PDA will originate from deep within the pulmonary artery, whereas the PR jet will only start from the level of the pulmonic valve. In parasternal short-axis aortic valve level, or the SSN suprasternal notch view, you will see three arteries coming off the arch of the aorta. Applying CW Doppler on the PDA from the descending aorta to the main pulmonary artery to get the velocity through PDA in meters per second, you will be asked to calculate the PASP from the systolic blood pressure and the velocity through the PDA. The pulmonary artery systolic blood pressure equals the systolic blood pressure minus 4 times V square, where V is the velocity through the PDA. For example, if the blood pressure was 120 over 40 systemic and the velocity through the PDA was 4.5 meters per second, then PASP is 120 minus 4 of the square of 4.5, which is 120 minus 20.25 times 4 equals 120 minus 80 equals 40 millimeters of mercury. So that's your pulmonary artery systolic pressure. If the pulmonary artery systolic pressure is higher, then the velocity through the PDA should be lower. If the velocity across the PDA is higher, then the pulmonary artery systolic pressure must be low. If PDA is severe, it can cause holodiastolic flow reversal in the abdominal aorta, just like in severe aortic regurgitation. If PDA patients present with pulmonary hypertension, you might miss the PDA because there's not much velocity through the PDA from the descending aorta to the pulmonary artery. When to intervene? When signs of volume overload are indicative of significant left-to-right shunt, closing the PDA is likely to prevent further left atrial or left ventricular enlargement, progression or development of PAH, and pulmonary hypertension secondary to left heart, and will possibly provide symptom relief if symptoms are present. Close the PDA if there is left-to-right shunt with left heart enlargement and symptoms, as long as the PVR is less than 1/3 systemic and the PASP is less than 50% systemic. Specifically, the 2018 Congenital Heart Guidelines say PDA closure in adults is recommended if left atrial left ventricular enlargement is present and attributable to PDA with a net left-to-right shunt, PA systolic pressure being less than 50% systemic, and pulmonary vascular resistance being less than 1/3 systemic. That's a Class 1 recommendation for PDA closure. Please note that there is no QP-QS ratio here in the criteria for PDA closure, unlike with the indications for ASD and VSD closure. The reason they don't use the QPQS ratio for PDA is that pulmonary blood flow and thus QPQS can be difficult to calculate accurately, since there may be significant differences in right versus left pulmonary artery flow caused by the flow from the PDA inserting into one of the pulmonary arteries. Also, remember that ventricular septal defects and patent ductus arteriosus have left heart enlargement, whereas atrial septal defects have right heart enlargement. If PASP exceeds 50% of the systemic pressure and pulmonary vascular resistance exceeds 1/3 of systemic resistance, the guidelines still allow for PDA to be closed, but just more reluctantly so, as a Class 2B recommendation, and this policy is the same that applies to ASDs, AVSDs, and VSDs. PDA closure in adults may be considered in the presence of a net left-to-right shunt if PA systolic pressure is 50% or greater systemic and or pulmonary resistance is greater than 1/3 systemic. That is a Class 2B indication. But they put a hard stop in not allowing PDA closure if PASP exceeds 2/3 of systemic pressure or pulmonary vascular resistance exceeds 2/3 of systemic resistance. This is the same policy for ASDs, AVSDs, and VSDs. PDA closure should not be performed in adults with a net right-to-left shunt and PA systolic pressure greater than 2/3 systemic or pulmonary vascular resistance greater than 2/3 systemic, Class 3 harm. PDAs are almost always closed percutaneously, not surgically. That's all for patent ductus arteriosus.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.